doctor come here. Maybe next time we have to have every doctor come here, so we should call for each doctor, and after we can have a point for each one come here. So maybe next time we can do find another method or many doctor come here is better. So today the Dr. Harry Tang she will be talking about the eye disco for watering with the eye. It's a medical for eye watering, and today Dr. Harry Tang she will be talking about this. Please for your presentation.
Thank you, Professor Thompson. Good afternoon, professors and colleagues. Today I want to talk about the subtle eye causes of oculitis. As for the causes of epiphora, as you all know, the first thing we think of is the outflow dysfunction. Maybe at the level of the puncture of the canalicular and the nasal lacrimal duct obstruction. It's kind of very obvious, and it has a straightforward management. Another thing that we think often at the first time when we see tearing patients is the reflex tearing. Often when you see patients with dry eye, ocular surface inflammation, or with ocular inflammation, uveitis, or other things. But one thing that not many people think of is eyelid disorders. An eyelid malposition like an entropion can be a cause of epiphora or pump failure. It's also an eyelid disorder. Can be a cause. And there are more subtle eyelid disorder like eyelid laxity and misdirection of tear. So the eyelid is like the floor of the sink. So when we have latent drainage system, but if the floor of the sink is not at the right corner, we'll have the water pooling at the corner of the sink, and it cannot go into the drain. So the eyelid is like the floor. It has to be at the right position for the tear to go into the lacrimal drainage system. And of course, we should think of the patient as has many causes, because very few patients will present with only one cause of epiphora. Maybe the patient will have both the dry eye and the obstruction of the lacrimal drainage, or have eyelid malposition together with the lacrimal obstructions. So sometimes after a BCR, we still have the tearing patients, so we should treat the ocular surface inflammation and the eyelid disorders. So now I'd like to talk about the type of epiphora. There's not only one type of epiphora. So the first question we ask the patient and the examiners for tearing eyes is where do you find the tear come from? Or do you have real tears coming down the cheek? If the patient say it is come from the medial corner of the eye, it is not specific, it is very popular. The cause can be reflex tearing, or the drainage system obstruction, or entropion. But if the patient says the tears come from the lateral corner, it is more often a eyelid disorder like a lower eyelid laxity or lower eyelid retraction. And if the tears come from the upper eyelid and lateral, we have the upper eyelid weak syndrome. And we will ask if the patient has a constant or just have a epiphora when you go out in the wind or when they watch TV. If it is a constant tearing, it must be an obstruction. Otherwise, some patients say that they only have tearing when they bend forward, like when they cook or when they do the gardening. So we have to look at the lower eyelid to see if they have a lower eyelid laxity. And there's a term that is pleural lacrimal. which means the patient thinks that they have a watery eye, but they don't have a real tear coming down the cheek. There's no spillover of the tears. We can think of a conjunctival cholesis, the raised lower eyelids, or kissing puncture, and talk about the kissing puncture later. So the subtle eyelid cause can be called the eyelid mascaraders for epiphora, and it comes in four categories. It can be a subtle ocular surface exposure, a misdirection of tear, a puncture-related disorder, which means a patent but dysfunction of puncture, and it can be a mechanical irritation, a very subtle entropion, or a meibomian gland inversion. So for the ocular surface exposure, you can see there are very obvious cases like upper eyelid lack of ophthalmos, like this patient, or lower eyelid lack of ophthalmos, like this patient. After cosmetic eyelid surgery, the patients can have a lower eyelid laxity in elderly patients, and you see that the tear comes out from the medial corner of the eye. But sometimes it's very subtle. Like this patient I see yesterday, this is a 77-year-old male, and he only have epiphora in one eye, and the lacrimal drainage is patent. So this patient has a very subtle snapback test on the eye of the epiphora. So we have to look for the laxity on the slit lamp to look for a subtle slow snapback test. So we look at a blink lachophthalmos. When we look at the patient, this is a patient. Normally we cannot see the blink lachophthalmos, but if you slow down the camera, we see that the upper eyelids do not go all the way to the lower eyelids. So this is a phenomenon that has been published before, and this is very popular after cosmetic eyelid surgery, or even after other eyelid surgery, or after external ECR. So in this paper, they found that even after 3 months after external ECR, about 1/3 of the patient still have blink lachophthalmos because of the damage to the nerve and to the orbicularis. And in dry eye, they also record the patients on a 30 frame per second video, and they found that the frequency and proportion of incomplete blinking or blink lachophthalmos very much higher in the dry eye patient. So how do you detect the blink lachophthalmos? Because it's not very easy to detect when we look at the patients. So we put the patients on the slit lamp, and we don't tell them to blink or to close the eye. We just talk to them normally, and you can see that the blink is not complete. And this blink lachophthalmos increase when patients don't pay attention. They increase in the afternoon or even when they sleep. When you put the fluorescein inside this eye, you see there's a pooling of fluorescein in the lower 1/3 of the cornea. So this is the area where the upper eyelids don't go to. They just come in here and then up. So this is the way we can find the blink lachophthalmos or incomplete blink. And this is very popular after blepharoplasty surgeries. Next, you see a very familiar face. This is me. I have a gritty sensation or orange body sensation when I wake up in the morning, but only on the dry eye. And I ask everybody to look at my eyes on the slit lamp. They don't find like a very mild dry eye, and they don't find anything very severe. So I wonder why. I have a like gritty sensation in the right eye in the morning. So look at this image. You see that the nasolabial groove is a little bit deeper on the left side. So you see there's a difference in the muscle tone, in the facial tones. So when I sleep, there's a very small lack of ophthalmos on the right eye when there is a very little weaker ocularis, and that's lack of ophthalmos will give me the gritty sensation when I wake up in the morning. And that's to say we have to look at all the patients' face when we have a patient with tearing disorders. And why it is called lack of ophthalmos? Labo is a rabbit, and so things that the rabbits don't close the eye completely when they sleep, and lack of hence the word lack of ophthalmos. So the treatment of incomplete blink, of course, is the treatment of evaporative dry eye, like lubricants, changing and the environments, wearing protection. We can train them to do the blink exercise, especially the patient who use computer a lot, or we can consider tapping of the eyelid at night. Then next, I talk about the misdirection of tear. There are two things that can cause a misdirection of tear. It is the upper eyelid wick syndrome. So I'm talking about the wicking phenomenon. When you put the coffee drop here, it will go up against the gravity of the earth. So the wicking syndrome will cause the tear to go up. So if you have a dermatoparalysis like this, and you have a contact between the upper and the lower eyelid, the water will go up. And then if you put the fluorescein inside, we see that the fluorescein go up to the upper eyelid. Then the outer corner of the eyelid is constantly wet, and it will cause a rash, like a baby diaper rash like this. So the patient will come with soreness, redness, excoriation, and patient often says that they have a stinky tears because of the bacteria who grows at the lateral corner, where it is always wet. So the treatment of the upper eyelid wick syndrome is a function of blepharoplasty. Normally we think of blepharoplasty is cosmetic, but this paper says that we have to do a functional blepharoplasty for patients with epiphora who have wick syndrome. And the patient has significant decrease in Munk score, epiphora score, compared to the baseline after the blepharoplasty. And likewise, in this paper, all patients achieve 18 to 100% improvement in epiphora following blepharoplasty. So we should think of blepharoplasty if we have a lateral epiphora. Another thing that can cause lateral epiphora is a conjunctival paralysis, or it can cause a lid parallel conjunctival fold like this. You can see that like one fold, several fold along the eyelid, and it will drain the tear outside to the lateral corner. And another thing to think of is the lower eyelid sac. Because there are several conjunctival folds, we don't have the reservoir for the tears anymore. Normally the tear will come into the sac, so it don't go outside. But now we don't have any place for the tear to come in, so it just go outside. The treatment for it we can discuss later. So the third thing to look for is a puncture-related disorder. We can have too large punctum, or we can have a megalocaruncle, or we can have a puncture conjunctival paralysis, and kissing puncture. We can see a too large punctum after a tearing of the punctum after propping, or if the punctoplasty is done too much, too large. When the pump, the lacrimal pump, when take effects, we have an amount of vacuum inside the lacrimal drainage system. But if the punctum is too large, we cannot achieve the vacuum. It will reduce the pipette function and reduce the pump function. So the water cannot be drained into the lacrimal drainage system. So normally when we do the punctoplasty, we do just a small punctoplasty and you just remove the vertical part of the canaliculum, never remove the horizontal part of the canaliculum. The second thing is you have to look for a very big caruncle. If you have a megalocaruncle, it will occlude the way of the water to go inside the punctum. So in this paper, you see that if you have a megalocaruncle, then do a partial lacrimal carunculectomy, and the epiphora will improve in 77% of the patients. Normally, the megalocaruncles do not go alone, even go with other disease, so we have to look for other disorders also. So the conjunctival colitis have two mechanisms to cause an watery eye. The fault we have discussed before, and if the punctum is occluded by the redundant conjunctiva, like in these patients, will have a tearing eyes also. So this is a method from of the author, Japanese author Yokoi. He reconstructed the conjunctiva in the lower meniscus in three parts. He reconstructed the middle parts first, and then the lateral parts. So the fold will just straighten out, and it will not block the punctum anymore. And then we have a kissing punctum. We have this kissing punctum when we see the triad. The first is a medioptosis or a fat prolapse. The second is a horizontal lower eyelid laxity. And the third thing is we see that the punctum touch each other all the time, even if the patient opens the eye very large. So we have the syndrome kissing punctum. You see in these ptosis patients, the patient complains of watery eyes. You see the tear here of the ptosis eye because she has the kissing punctum, and this patient does not have the ptosis but have a fat prolapse here, and he also has a kissing punctum. So if the punctum cannot get apart, the water cannot go inside the punctum, and in this syndrome will have to be treated by the ptosis repair and the fat prolapse repair, and we have to do the lateral tarsal strip to tighten the lower eyelid. And the fourth thing, the last thing, is a mechanical irritation to the ocular surface. Normally, if you see an entropion, it is very obvious that the patients have tearing. But in this patient, when the patient look up, you don't see the entropion. But there's a condition that we call meibomian gland inversion. Normally, we can see the meibomian gland when the patient look up, but in this patient, we do not see that. So this is part of the early spectrum of the upper eyelid cicatricial entropion, before it becoming clinical apparent, before we can see a real entropion. So this will cause patient to have limb-related discomfort, will cause pseudo-spasm, will cause watery eye, sore eye, and breathing sensation. So how can we detect this? It is called a cotton tip test. So we put a cotton tip on the upper eyelid to invert the eyelid, and then we see the meibomian gland. If it is positive, we will have a meibomian gland inversion. So this can be managed by lubricants, but it also managed by surgery. And in this patient, we see a very subtle staining on the superior cornea. And this condition can be presented in kind of many diseases, like in floppy eyelid syndrome, in facial pansy, or even in normal patients. So this is one of the procedures you do if you have a meibomian gland inversion. It is an anterior cervical tarsoplasty. We split the anterior portion and the posterior portion of the eyelid. And then we see an inward curl of the inferior edge of the tarsus. So you have to thin out the tarsus to get rid of the inward curl. Like this, we use a blade to scrape, to thin out the lateral and the medial part of the tarsus. So if the tarsus becomes thinner, we won't have the inward curl anymore. And then we reattach the anterior portion about 1 or 2 millimeters posterior to the edge of the tarsus. So that is all of my talk today. Thank you for listening.
Thank you very much, Dr. Habib. Thank you for your talking about the core or what the eye and core is happen when you have the eye watering. And any question or comment for Dr. Habib? Dr. Cương, yes.
Yeah, thank you, your integrated presentation. You heard the panorama contact of causes that due to eyelid. You heard, I think, five big problem that we give eye watering. But I daily working and some patients have facing paralysis, and also we repair the eyelid position as well with the lateral tarsal chip, do something like that. It good, and I mean that it's a view of anatomic point that good in well positioned, but see or hear still eye watering. You have something to explain why?
You mentioned is a facial paralysis. Yes, especially when you do the lateral tarsal strip, you can tighten the lower eyelid, but the pump function is not like very normally working, because when we have the pump functioning, the medial punctum has to be drawn medially, and the lacrimal sac has to be enlarged, and then vacuum effects will take place. But you cannot like restore 100% of the orbicularis function in that situation. So you just eliminate the lateral water drain, but you cannot retract, track the water inside the lacrimal sac.
Yeah, I see. And someone talk about the mechanism of eye water in that case. After a long time of facing nerve palsy, you have something like gum dây phẩy, I mean hypersecretion of 7 nerve palsy and hypersecretion of water also. Yeah, and therefore hard to deal with that. Thank you.
Thank you very much. So, any question or comment for Dr. Habib? Yes, Professor Kuh.
Thank you very much for your very good presentation and beautiful English. So I would like to ask you that for the